Good morning, good afternoon, good night. Thanks for tuning in to another session of Lab Medicine. I'm Rob Fitzgerald, and I have about 9 slides that we're going to go through, and we'll talk about the classification of diabetes mellitus. This is a table that some of my students groan when I show, but it's very useful, and if you understand this table, you can understand changes in glucose in a whole variety of disease states. So it's sort of worth committing this one to memory. And the left side of the table is easy. Glucose is really the only thing that drives glucose down is insulin. So in the presence of potassium, insulin stimulates receptors causing glucose to be taken up into cells. So blood concentrations of glucose go down. A variety of things increase glucose, and so we'll just go through those quickly. Growth hormone is an insulin antagonist. If you antagonize insulin, then you're going to get an increase of glucose. Makes sense. ACTH, adrenocorticotropin hormone, is what stimulates the release of cortisol, and so ACTH works through glucocorticoids, and the next level down we have glucocorticoids, which one of their primary functions is gluconeogenesis. And so in the setting of excess cortisol, you break down non-carbohydrates into glucose, and so you get hyperglycemia. Epinephrine works through both glycogenolysis and gluconeogenesis. So does glucagon and thyroxine. So thyroxine is T4. That's what's coming from your thyroid gland, which is eventually converted into the active form T3, which causes both glycogen breakdown and gluconeogenesis. Somatostatin is really, I think about somatostatin as an inhibitory secretor, so it basically blocks secretion of a variety of different things, including insulin. So if you block insulin secretion, you get hyperglycemia. So if you know this table, you can figure out what happens in Addison's disease, what happens in Cushing's disease, what happens in hyperthyroidism, hypothyroidism. So worth knowing, just spend a little time and understand this table and understand the mechanisms, and then you won't have to memorize as much. So back to diabetes, the type 1 diabetes, we used to call it juvenile onset. Most often it happens in younger people. But it's probably better characterized as being insulin dependent. It's an autoimmune disease where you've had autoimmune destruction of the beta cells. If you destroy the beta cells, they're responsible for synthesizing insulin, so you get hyperglycemia. So laboratory findings, the one to know is a glucose greater than 126 milligrams per deciliter is the cut point for diabetes, and we'll talk about that in the next section. How do we do that, and how do we make those interpretations? But the 126 value is worth knowing. A normal person's glucose is less than 100, and those importantly have to be done in a fasting state. Type 1 diabetics oftentimes have glucose in their urine, so they get glycosuria. Their renal threshold gets excreted. In the absence of insulin, your body is looking for other energy sources, and it breaks down fatty acids. So fatty acids become your energy source, and they result in the end product of that breakdown is acetoacetate and beta-hydroxybutyrate, keto acids that show up and cause the ketoacidosis associated with type 1 diabetics. So ketonuria and ketonemia are frequently found. Insulopenia, so we typically don't measure insulin in making the diagnosis, but if you did, they would have low levels of insulin because of the destruction of the beta cells. Glycated hemoglobin is our marker for long-term monitoring, and if you have hyperglycemia for a prolonged time, you get elevated glycosylation, and your hemoglobin A1C is high. Oftentimes at diagnosis, type 1 diabetics can have islet cell antibodies, and these are what are causing the autoimmune destruction of the beta cells, so that can be useful for the diagnosis of type 1 diabetes. Clinical findings, they're prone to ketosis because they don't have any insulin. They have a lifelong dependence on insulin because of the destruction of the beta cells. As we mentioned, it typically is young onset. Positive family history, sometimes they'll have a brother or sister that has diabetes, and oftentimes it's associated with other endocrine organs, so hypothyroidism or hypoadrenalism due to an autoimmune basis. So switching to type 2 diabetes, adult onset we call that, or non-insulin dependent. Really, it's an insulin resistance. Either they have less receptors, or the receptors are not as responsive. In laboratory findings, we use that same cut point, greater than 126, puts you in the diabetic realm. They'll have abnormal glucose tolerance tests if they're done. Really, the best test to start out for a screening of diabetes is a fasting plasma glucose. It's our most sensitive. It's a relatively easy test. And if it's abnormal, then we'll typically follow that up on a different day and confirm it. They have variable glycosuria. Their renal thresholds are a bit different than type 1s, and so it depends on the degree of hyperglycemia, whether or not you'll be able to pick up glucose in their urine specimens. Elevated glycated hemoglobin, and I sort of use those terms interchangeably, glycated hemoglobin or hemoglobin A1C. We'll talk about that in the next section when we talk about the laboratory diagnosis. But essentially, they're measuring a covalent attachment of glucose to hemoglobin. Variable levels of insulin. So type 2 diabetics, and that's another reason that we don't measure insulin in these patients, is because, one, it's a difficult measure to do. Insulin's a protein. It gets broken down. There's proteases, and the pre-analytical factors are significant that have to be controlled in order to get an accurate insulin measurement. As well as in a setting of type 2, it could be low, high, or normal, and really is not that informative. And as we said, really it's a decrease in number of insulin receptors. In between normal and diabetes, we have impaired fasting glucose or impaired glucose tolerance, depending on what term you'd like to use. And really, the laboratory findings are just right in the middle between, less than 100 is normal, greater than 126 is diabetic, so it's in that intermediate range, puts you in the impaired fasting glucose. If you do a glucose tolerance test, it's the same thing. They're in the middle. A normal glucose tolerance test at 2 hours is less than 140. Diabetic range is greater than 200. So if you're in that 140 to 200 range, you're in the impaired fasting glucose. So clinical findings, really these are at higher risk for many of the things that diabetics develop, and really we want to catch these patients early so that they don't develop full-blown diabetes and get atherosclerosis and all the other adverse events. Typically they're higher age, and as we pointed out, really these guys, our concern here is that they're going to develop a diabetes. And what's interesting is that the average person has diabetes for 7 years before they get diagnosed. And that's really a tragedy. It's a very simple lab test, and we should be doing a better job of that. Gestational diabetes happens during pregnancy when women either become diabetic or impaired glucose tolerant. Oftentimes it does resolve after the pregnancy, but in some patients, they need careful follow-up to make sure that they don't develop full-blown diabetes. Really what's happening is that there are other things that the pancreas can't overcome, the placental secretions of estrogens that cause the hyperglycemia. Last one we're going to talk about real quickly is MODY. That's maturity onset of diabetes of the young. So this is a young person who has a genetic defect with the beta cells that are causing them to develop sort of a picture of like a type 2. So they're non-insulin dependent, but they get hyperglycemia. And there's 5 or 6 different types, and really they range in severity from mild to clinically significant disease. And oftentimes they're going to be genotyped to identify which one they have. So asymptomatic hyperglycemia to acute illness, and again, that's where you would follow up an elevated fasting plasma glucose if you couldn't diagnose them as type 1 or type 2. So this chart is really sort of a review of the first chart that I showed, and it's looking at hyperglycemia and other disease states. So post-pancreatectomy, that makes sense why you would have hyperglycemia. You've removed your source of insulin. The next three are also very similar. Cancer of the pancreas, pancreatic cysts, and hemorrhagic pancreatitis. All of those are destroying pancreatic tissue, and in which case you're losing your ability to synthesize insulin. So you get hyperglycemia in those cases. Acromegaly, and so if you remember our first slide, the acromegaly is caused by an excess of growth hormone. And if you have too much growth hormone, then that's an insulin antagonist, and you get hyperglycemia. Cushing syndrome really is any increase of excess cortisol. So cortisol acts through gluconeogenesis and causes hyperglycemia, so that's a common finding in Cushing syndrome. Pheochromocytoma is a neuroendocrine tumor that secretes epinephrine, norepinephrine. Both of those act to increase glucose through both gluconeogenesis and glycogenolysis. Glucagonoma makes sense. You have too much glucagon, you get hyperglycemia. Somatostatinoma really blocks the secretion of insulin along with a variety of other things and ends up in hyperglycemia. Primary aldosteronism, again, if we remember that first chart, we can figure out all of these, this whole list of disease states on this slide. Primary aldosteronism, aldosterone is a mineralocoid, and so it acts to reabsorb bicarb and chloride and excrete hydrogen ions and potassium ions, and that's its primary function. If you have primary aldosteronism, you get really large increases of aldosterone, and it has both mineralocoid and glucocorticoid effects. So we think of aldosterone as a mineralocoid with weak glucocorticoid effects. And so when you have too much aldosterone, you get a glucocorticoid effect and you get hyperglycemia. Hyperthyroidism, working through the thyroid hormone T3 to cause gluconeogenesis and glycogenolysis. Hemochromatosis is due to excess iron. It's a defect where you absorb too much iron, and iron, when it's not bound to its binding globulin, thyroid binding globulin, iron binding globulin, you get tissue damage. So once iron saturates its binding globulin, it starts to cause inflammation, and it causes liver damage, it causes pancreatic damage, and that's going to be the mechanism for hyperglycemia. Malnutrition, when you supplement them, their pancreas has been subfunctional for some time and hasn't had the stimulation to secrete insulin, and you get hyperglycemia in that setting. Many drugs can cause hyperglycemia, and then there's a variety of genetic conditions. So our next version, our next slideshow, will actually talk about the laboratory diagnosis of and monitoring of diabetes mellitus. So I hope you can tune in, and thanks for listening.